Hello, you beautiful people. I shall be continuing with my playlist topic playing with joints. So, we shall be discussing about large vessel vasculitis today, and it comprises of two topics in vasculitis. So, first is the giant cell arteritis. Now, what is the giant cell arteritis? It is the large vessels which are involved. Particularly, it is the superficial temporal artery which is involved, or the next common is the vertebral artery. Now, there is this transmural involvement, and there are mononuclear cells, giant cells, and granulomatous inflammation, but there is no fibrinoid necrosis as such. So the pathophysiology says there are certain dendritic cells which are causing the lymphoid cells and the T cells to secrete this Th1 more than that of Th17, and this Th1 will cause the interferon gamma and the interleukin 6, and this interleukin 6 which was released causes inflammation, and interferon gamma causes ischemia. So, actually, there is this interferon gamma which is responsible for the granulomatous inflammation. So, it is the most common vasculitis, and the vessels involved are the superficial temporal artery. Then we have the vertebral artery, which is the second most common. Third most common is the ophthalmic, and then we have the fourth, that is posterior cerebral artery. Now, this is seen in like other vasculitis, it is more common in females than males, but the ratio says it is 2 is to 1. So it's fine. It's not like 9 is to 1. So when we can even suspect with the males, particularly who are about 50 years of age. Now, there is this polymyalgia rheumatica, which is present in these patients. Now, they have this association which says 50 to 70% of giant cell arteritis will be having this polymyalgia rheumatica, and 10 to 20% of the polymyalgia rheumatica who are already diagnosed will be having a giant cell arteritis as an association. Now, what is this polymyalgia rheumatica? It is nothing but early morning pain and stiffness, particularly in the pelvic girdle, neck region, and the shoulder. Now, there would be raised ESR, and they have 100% response to steroids. There would be bursitis and tendinitis, but there is no muscle atrophy as such. So, this is particularly seen in more than 50 years of the age group. It is itself a individual disease, but its association is strongly with the giant cell arteritis. So, the risk factor for the giant cell arteritis involve smoking, varicella zoster virus, HLA-B104 genetic cause. Then we have notch receptor upregulation, and we have MICA5 allele that can be associated. So we come to the symptoms. So there are certain typical and certain atypical symptoms. Typical symptoms are like headache, as we all are aware, and there would be fever, fatigue, weight loss. These are the constitutional symptoms, and the visual symptoms are also there in typical. So along with a jaw claudication. So this headache is something which is a new onset, boring, deep, recurring type of headache, and this is usually more than 50 years. That the temporal artery, whenever we palpate, try to palpate, there would be nodularity, there would be tenderness, and there would be decrease in pulsations. Then we have visual loss also in such patient, that is because of anterior ischemic optic neuropathy, and visual field defects are seen. Now this is something which is temporary and could be unilateral, and there could be ophthalmoplegia as well as ptosis, as well as the patient will be complaining of jaw claudication. So now we have this atypical giant cell arteritis. Atypical will not have such common features. There would be pyrexia of unknown origin. There could be as well as C5 radiculopathy, which is very common in Indian scenario. So it is very hard for us to distinguish. So this will hold as a diagnosis of exclusion. There would be a throat pain or cough, and one third of the patient will have aortic aneurysm. So coming to the diagnosis, we will diagnose the patient based on biopsy. So it is really hard for peripheral centers to diagnose this. I can understand that, but this is how we diagnose this. So there would be certain skip lesions, and on the color Doppler there would be this halo sign that will be seen. And there is this parasailing histiocytosis also. So coming to the treatment, every vasculitis is incomplete without the steroids. We have to give steroids, 1 milligram per kg. We need to taper to a low dose in 12 to 16 weeks. And if there is any flare, there is this pathology related to interleukin 6, so interleukin 6 inhibitors such as toxicizumab can be tried. Coming to the next entity, which is the Takayasu arthritis, which is also called as aortic arch syndrome. Now, the most common vessel which is involved is the subclavian artery. Then, this is common in female, which is 9:1, very, very common. So, it is common in young onset, that is less than 40 years of the age group. So, this is the HLA which is associated is HLA B52 and 67. And like giant cell, it is not associated with any smoking or no varicella zoster association. So stenosis is very much common, and there will be constitutional symptoms, but only in 20%. It is not so common like that of in giant cell arthritis. So there will be the upper limb claudication, not jaw claudication. There is a pulseless syndrome, which is this is called as a pulseless syndrome, and because of the unequal pulse that are present in upper limbs. And there is carotid bruit as well as carotidynia. There is tenderness over the carotids. So the vertebral artery will be involved in such patients and can cause strokes. And aortic arch is also involved, so that can also cause aortic regurgitation. So remember that the renal artery and the pulmonary artery are very uncommon for involved in as to involve in giant cell arthritis. And the best measure will be the MR-angio. So here also we go with the steroids, and for aortic regurgitation and any of the stroke protocol we have to follow, as well as surgery has to be done. So there is one classification for that of Takayasu's arthritis. So this is the type 1, which says that there are branches of the aortic arch which will be involved. Then 2A, which is the ascending aorta, aortic arch and its branches. There is 2B, there is ascending aorta, aortic arch and its branches with the thoracic and descending aorta. Then 3 involves the thoracic, descending aorta, abdominal aorta and or the renal arteries. Then 4, which is the abdominal aorta and or renal arteries, and 5, which is combining of the 2B and that of the 4, which sees that it is an ascending aorta and aortic arch and its branches with thoracic and descending aorta with abdominal and or the renal arteries. So this was the all about the large vessel vasculitis. I will come up with the other vasculitis in next few chapters. Thank you so much for listening.